بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنكمل موضوعات من acid base metabolic disturbance. Today we'll talk about Metabolic Alkalosis Clinical Pearls in our part of this acid base electrolyte disturbance, and from nephrology point of view. نتوكل على الله عشان الوقت. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا الا ما علمتنا انك انت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وكن اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. ان الله وملائكته يصلون على النبي يا ايها الذين امنوا صلوا عليه وسلموا تسليما. صدق الله العظيم. اللهم صل وسلم وبارك على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. من نفسي من السوشيال ميديا. This primary metabolic alkalosis is very nice slide to remind you when you will see any patient with metabolic alkalosis. Just to give you a rapid review. These are patient volume depleted or volume expanded. Volume depleted will activate the secondary hyperaldosteronism, and volume expanded or volume overload will may be related to primary hyperaldosteronism. As regard the volume depleted or effective arterial blood volume depletion, maybe as you will check urine chloride. If urine chloride is low, is associated with vomiting and energy suction, and the low chloride intake and diuretic lead or remove diuretic use. High urine chloride, either recent diuretic use, Bartter Gentleman syndrome. If patient volume depleted or volume expanded, we'll check plasma renin activity with high aldosterone, high renin, this with renal artery stenosis, malignant hypertension, renin secreted tumor. If low plasma renin activity like adenoma or hyperplasia, primary adrenal hyperplasia, or corticoid excess, or glucocorticoid remediable aldosteronism, Cushing syndrome, Liddle syndrome with low BRA. Plasma renin activity with metabolic alkalosis and volume expansion. We'll come to definition. Definition for metabolic alkalosis. This is a primary increase in the bicarb. If you see one patient to pH more than 7.45 or bicarb more than 26, this will guide you. This patient will go to metabolic acidosis and metabolic alkalosis, and this will be compensated by respiratory acidosis from hypoventilation, from effective metabolic alkalosis, increase arterial partial CO2. Is it appropriate response to increase in the serum bicarb? Metabolic alkalosis characterized by elevated pH, increase in bicarb, and elevated partial CO2. Because metabolic alkalosis, the course of metabolic alkalosis divided into either generation or maintenance or recovery phase. We have three phases to maintain metabolic alkalosis: generation, maintenance, and recovery. This is the course of any metabolic alkalosis. If any patient develops metabolic alkalosis, you will start by generation, and the other factor will keep this maintenance phase and the recovery phase. This should be our job. Generation occurs either by loss to be. This is the key of our presentation today. If you will lose hydrogen, you will gain alkali, or you will keep the alkali in your body with loss of acid, no balance now. This will end by metabolic alkalosis. Any mechanism, any cause, he should undergo under this mechanism: loss hydrogen and gain alkali, loss hydrogen and gain bicarb. This is the main mechanism for metabolic alkalosis in general. For any causes, from the cause we'll discuss now. In generation phase, this occurs either by loss hydrogen from the body or additional alkali by any of one of the causes we'll see now on our table. Causes of metabolic alkalosis: either chloride responsive alkalosis, chloride resistance alkalosis. You can take a picture and you can read these causes. Chloride responsive means contraction alkalosis or effective arterial blood volume depleted. This patient already dehydrated or intravascular volume depleted, like GI causes, like vomiting. The most common cause of metabolic alkalosis is vomiting. Energy suction already in ICU. We'll see all this patient in ICU. Congenital chloride diarrhea. We saw many patients with congenital, especially in pediatric. Same mechanism with villus adenoma. And post-hypercapnia. Will come to all this. Contraction alkalosis, cystic fibrosis. We'll see this with hyponatremia and other. Severe potassium deficiency, this will end by also metabolic alkalosis. If you correct the potassium or hypokalemia, will correct your metabolic alkalosis and will come to that point. Milk alkali syndrome, gastrocystoplasty, Zollinger-Ellison syndrome, drug-induced associated, the most common loop diuretics, as a diuretic, poorly absorbed anion, like penicillin, phosphate, sulfate, all this, sodium bicarbonate, baking soda intake, this will lead to chloride responsive alkalosis, sodium citrate, lactate, acetate, all this will be transferred to bicarb at the end. Inhibition taking sodium citrate, lactate, gluconate, acetate. If you treat metabolic alkalosis by ringer lactate, lactate will be transferred to bicarb. This is a wrong management for your patient. Antacid, most antacid like PPI will develop hypomagnesemia and will end by hypokalemia. This also aggravated metabolic alkalosis, will come to that point. And transfusion, especially containing citrate and blood containing citrate, will end by bicarb. At the end, chloride resistance alkalosis, especially hypertension associated primary aldosteronism, even the hydroxy dehydrogenase type 2 deficiency, patient taking a high amount of licorice and fludrocortisone administration, Cushing syndrome, remediable aldosteronism, and hyperrenism and hyperaldosteronism, malignant hypertension, and renin-secreting tumor, Liddle syndrome. Normotation like Bartter syndrome, Gitelman syndrome, also other causes of metabolic alkalosis, hypercalcemia, hypoparathyroidism, and post-feeding alkalosis. The regard will come to second phase now, the maintenance phase following generation, and now we'll go to persistence of metabolic alkalosis in our body by persistence volume depletion and chloride is a chloride responsive type of metabolic alkalosis. Chloride deficiency and potassium deficiency and low GFR and excess mineralocorticoids, especially cortisone, will work like aldosterone, and it will enhance more secretion of potassium and hydrogen. Fluosyl hydrogen will keep alkali, and this will you will keep maintenance phase of metabolic alkalosis. And we'll come to all this by diagram now. Chloride depletion sustained metabolic alkalosis by the following mechanism, as in before, the main causes, and we'll come to discuss each one in a separate discussion now. Chloride depletion inhibit potassium reabsorption and is sick ascending. If you know, the main mechanism of diuretic or loop diuretic or Bartter syndrome, especially in diuretic, you replace the chloride position in the sodium potassium to chloride co-transporter channel. If the chloride replaced by Lasix, this will lead to inactivate this sodium potassium to chloride channel or co-transporter in the sick ascending limb of Henle. It will inactivate this channel and no more sodium potassium reabsorption, and this will end by hypokalemia, and this will aggravate also metabolic alkalosis. We'll come to that point in a future slide. Along with hyperkalemia and with potassium and sodium reabsorption is also burden is sick ascending limb of Henle. This will cause more delivery of sodium to the cortical collecting duct. It will enhance reabsorption via inactive channel, as we discussed before, hyponatremia or hyperkalemia or hypokalemia. It will enhance reabsorption of sodium and will lead to increase the luminal inside the tubules, the renal tubules charge negativity. And it will activate the wrong channel to secrete potassium with hydrogen and replace the sodium inside the cell. This lead to aggravate your metabolic alkalosis. Loss hydrogen will end by gain alkali. Also, the same chloride depletion cause decreased delivery of chloride to cortical collecting duct, where bicarb secretion is reduced via apical chloride bicarb exchanger located in the intercalated cells. P cells are responsible for bicarbic secretion, and this bicarbic secretion or secretion in the urine depend on the chloride amount. If you have chloride deficiency, this will end by increase the bicarbic secretion and will end by metabolic alkalosis also. Potassium depletion maintain metabolic alkalosis by the following mechanism, as we saw in the previous causes. Decrease the intracellular pH due to movement of hydrogen into the cell to replace the potassium loss in hypokalemia patient. and increase bicarb reabsorption by enhanced activity of luminal sodium hydrogen ATPase and the basolateral sodium bicarb transporter in the proximal tubule, increased distal tubule acidification by activation of hydrogen ATPase in response to increased production of ammonia, decrease in sodium potassium 2 chloride co-transporter activity. Sorry, I didn't forget to magnify this picture. Decrease in sodium potassium transport activity to chloride depletion in the sick ascending limb, reduction in GFR by both potassium and chloride depletion. Also, this will maintain your metabolic alkalosis. A recovery phase with correction of chloride and potassium and treatment, underlying causes will improve metabolic alkalosis, and will come to this by sodium chloride the main and potassium also depletion. All this will enhance recovery from metabolic alkalosis, and will come to that point. So we'll come to our introduction today, metabolic alkalosis, and this is what means, as I told you before, increase in pH more than 7.45, to primary increase in the serum bicarb also, bicarb more than 26 or whatever. Metabolic alkalosis result from alkali, either from alkali accumulation or acid loss, either both. Any mechanism for any cause we mentioned before, either will lead to alkali gain or acid loss, and it's associated with secondary increase in the CO2. Metabolic alkalosis is a common acid-base disorder, especially in critically old patients. But now, don't forget that when anyone asks you what is the most common acid-base disturbance you will face in your career in hospital, especially in hospitalized patient or ICU or critical patient, the metabolic alkalosis is the most common acid-base disorders, especially in critical ill patient, not in metabolic acidosis. Pathogenesis of chronic metabolic alkalosis include two derangement, generation of metabolic alkalosis via either gain of alkali or loss of acid, and maintenance. Generation and maintenance. This chronic metabolic acid alkalosis mechanism, either gain of alkali or loss of acid and maintenance, followed by maintenance metabolic acid alkalosis by increased tubular bicarb reabsorption. This from failure our kidney to secrete excess alkaline. تمام. لما يبقى عندك كمان جي اف ار وكده، الكليه عماله تعمل ري ابزوربشن والعيان هايبوتنشن وات ايفر، ما بيحصلش سكريشن للبايكارب، فبيحصل له ري ابزوربشن بالبروكسيمال تيبيول. Metabolic alkalosis again the most common acid disorders in hospitalized patients, particularly in surgical critical care unit. Mortality increase with pH increase also. We'll come to this study later. We need arterial blood gases required to diagnose any acid-base disorders, as we mentioned before. High serum bicarb can result from metabolic alkalosis or metabolic compensation of respiratory acidosis. High pH more than 7.45 and low arterial hydrogen defined as alkalemia. pH more than 7.45, this alkalemia. If the serum bicarb is high, alkalemia is due to metabolic alkalosis. Now, just the pH will give you alkalemia or acidemia. If pH more than 7.45, this alkalemia. We'll go to second one to check bicarb. If the bicarb is high, it's alkalemia. Now, metabolic alkalosis. If the partial CO2 is low, the alkalemia will be respiratory alkalosis. Metabolic alkalosis will see bicarb already more than 28 millimole per liter, and venous CO2 more than 30 millimole per liter in metabolic alkalosis. Gain of alkali or loss of acid lead to metabolic alkalosis. If serum bicarb is high and the partial arterial CO2 is low, the alkalemia is due to mixed acid-base disorders. Now, if serum bicarb is reverse now, not in the same direction, in opposite direction. Bicarb high and the CO2 is low, alkalemia due to mixed acid-base disorder, namely بيسموها metabolic alkalosis and respiratory alkalosis. Simple acid-base disorder due to change in CO2 or serum bicarb with appropriate metabolic or respiratory compensation. If all in the same direction, all increase this simple acid base, or all increase or decrease the simple acid base disorders for bicarb and the CO2 in opposite directions. This means we are dealing with a mixed acid base disorder, as we know already. Metabolic alkalosis is usually accompanied by hypokalemia, hypochloremia. The reduction of chloride is not accompanied by hyponatremia. Line gap usually slightly elevated metabolic alkalosis due to increased plasma protein negative charge. To summarize, simple acid disorders, bicarb and the CO2 moves in the same direction. Both are up in metabolic alkalosis and respiratory acidosis, and both are down in metabolic acidosis and respiratory alkalosis. In mixed acid-base disorders, bicarb and the CO2 moves in opposite direction. Respiratory compensation, just don't forget this, partial arterial CO2 40 is the normal, plus 0.6 multiplied by serum bicarb minus 24. This will give you the actual partial arterial CO2 in respiratory and metabolic alkalosis. Don't forget this, or each increase in 1 millimole per liter rise in the bicarb above 24, this will increase the partial arterial CO2 0.6 millimeter, or another way, every 10 millimole per liter increase in bicarb, this will equal around 6 millimeter mercury rise in partial arterial CO2. 1 millimole 2.6 and 1 millimole rise in the bicarb will raise the BCO2 0.6, or 10 millimole bicarb equals 6 millimeter mercury in the partial arterial CO2. And don't forget this equation for actual metabolic alkalosis CO2 partial CO2 correction. 40 plus 0.6 multiplied by bicarb minus 24. This example, if you like to read later. Respiratory compensation, metabolic alkalosis are combined by alveolar hypoventilation, which takes minutes to hours to occur. Respiratory compensation usually does not result in complete pH normalization. Metabolic alkalosis, partial arterial CO2 is rarely over 55 millimeter mercury. pH that is close to the normal range may indicate a mixed acid disorders, namely metabolic alkalosis and respiratory acidosis. Examples such as acid-base disorders, patients with chronic respiratory acidosis due to COPD who develop concomitant metabolic alkalosis due to diuresis. What is success when you see this in an EBG in the bottom part of our EBG? The EBG under the standard normal condition, pH 7.40, partial arterial CO2 is 40 and temperature 37, and the basic success should be 0 millimole per liter. This under temperature of 37, under acid-base disorders or EBG reading. Under reading excess, base excess is defined the amount of strong acid millimole that need to be added to 1 liter of fully oxygenated blood in vitro to return an EBG to above defined standard condition. This excess is negative in metabolic acidosis and positive in metabolic alkalosis. I will clarify that. Now, basic excess بالماينس metabolic acidosis, positive in metabolic alkalosis. The normal range here is -2 to +2 millimole per liter. EBG, for example, for a patient with severe metabolic alkalosis, pH 7.5, and the partial arterial CO2 49, and bicarb 38 millimole per liter, and we have basic excess 14. This means you need 14 millimole for each liter of oxygenated blood to return this pH to normal. You need to add this hydrochloride. This now we are this basic this now we have alkali more. You need to add hydrochloride or acid to do plans for this to return this base to normal pH and CO2. We need to add it 14 millimole hydrochloride. Incidence of metabolic alkalosis, most common acid-base disorders in patients with intensive care unit. did in large Norwegian study, and alkalosis was found as a simple or mixed acid-base disorders, including post-hypercapnic alkalosis in patients with COPD on mechanical ventilation. Don't forget that. Also, another prospective study showed this enrolled around 293 general surgical patients. Most of 50% or 50.5% developed metabolic alkalosis as other acid-base disorders were uncommon. The most common one, 50.5%, is metabolic alkalosis. Metabolic alkalosis persists in 31 patients, indicating a high mortality rate of 32%. Another Hodgkin et al. Analyzed around 13,430 ABGs obtained from hospitalized patients. Metabolic alkalosis were found around most common acid-base disorders, 51%, followed by respiratory alkalosis, 21%, and respiratory acidosis, 27%, and the least one, metabolic acidosis, 12%. Another prospective study already, 409 patient medical and surgical patients, shows around that mortality was 48%, around 50% in patients with pH more than 7.6 with metabolic alkalosis. Renal net acid excretion, kidney play a major role in the acid base regulation with the lung also. The three components of renal net acid excretion are ammonium, acid excretion, either ammonium or titratable acid or urinary bicarb plus. All bicarb filtered through the glomeruli is reabsorbed under the normal physiological condition. The kidney generate new bicarb to replace the bicarb used to buffer acid in the body. About 80% to 90% of this filtered bicarb reabsorbed in proximal convoluted tubules, 15% seek ascending limb, 5% in the collecting duct. The two cell types in the collecting duct, we have two intercalated cells, alpha and beta. Alpha responsible for hydrogen excretion, and the beta intercalated cell responsible for bicarb secretion. And we'll come to that. The beta intercalated cells in our collecting duct is responsible for bicarb secretion. We saw here this bendrin channel. We have this chloride and the bicarb. The chloride within the tubular lumen. If the chloride depleted in an patient volume depleted, this channel will not work and no more bicarb secretion. Just take care from this diagram now. If you have volume depletion or chloride responsible, contraction alkalosis, whatever, metabolic alkalosis, and we have chloride depletion here, this channel will not happen. This will end no more bicarb secretion, and all bicarb will be retained in our bodies. This is the cause of hyperkalemia. And this will end by more hydrogen go to our blood. Now, this will end by this acidosis increase, bicarb retained, and this will end by increase metabolic alkalosis, because this chloride depletion will lead to inactivate this bendrin channel and no more bicarb secretion. The alpha intercalated cells is the blood, and this is the lumen. The alpha is responsible for secretion of this hydrogen. If we have this also in the lateral membrane, potassium, sodium ATPase channel here, this will reabsorb to the blood 3 cation of sodium with 2 potassium here. If we have volume depleted or chloride depleted or potassium hypokalemia for this patient, this will lead to disturb this channel here. If we have hypokalemia, this will lead to inactivate this channel from hypokalemia, no more hydrogen secretion. This will end by more hydrogen secretion. If we have this, the potassium will be reabsorbed more here from hypokalemia, and the hydrogen will be secreted, and this will end by the mechanism of potassium here. And this mechanism, this is a mechanism how hydrogen secreted in hypokalemia, because the reabsorption of the potassium will end by secretion of this hydrogen. If we have loss of hydrogen, this is our mechanism of alkalosis. If you lose hydrogen, this you will gain alkali. This will end by metabolic alkalosis. Alpha intercalated cells are generated by carb exist via this basolateral chloride bicarb exchanger. The intercalated cell generates bicarb which exists the cell and enters the tubular lumen via apical chloride bicarb exchanger. The name is LC26E4 protein bendrin. Bicarb secretion in the collecting duct require luminal chloride and is inhibited by chloride depletion. Chloride depletion is critical in the generation of metabolic alkalosis, as we mentioned in the previous diagram. Chloride depletion increases distal sodium delivery and reabsorption, which stimulate potassium hydrogen secretion. If we have chloride depletion, this will increase the distal sodium delivery and reabsorption. This will stimulate reabsorption and reabsorption. This will stimulate potassium and hydrogen secretion in the collecting duct. And this explains the importance of isotonic solution in the correction of metabolic alkalosis. The density of intercalated cells also and the bendrin are both reduced in case of hypokalemia. Hypokalemia also affects this bendrin and the density of the intercalated cells. Therefore, hypokalemia limits bicarb secretion. This explains the importance of correction of hypokalemia in management of metabolic alkalosis. Because if you have hypokalemia, this will lead to decrease this bendrin channel and the beta intercalated cells. This will affect by hypokalemia. With bendrin, what is the job of this bendrin channel? This reabsorb bicarb, secrete or excrete bicarb in the urine after absorption of chloride. If with hypokalemia present, this will affect also this. How does metabolic alkalosis persist? We have two steps required for metabolic alkalosis. The first step, generation, as we mentioned before, and the second step, maintenance, as we mentioned before. Exogenous and endogenous mechanism resulting in generation of metabolic alkalosis. Is the cause of generation. Either came from infusion or ingestion of bicarb, sodium bicarb, or bicarb precursor like citrate, like acetate, as we mentioned in our table before. Hydrochloric acid loss patient with vomiting, chloride-rich diarrhea, or NGT suction. Hypokalemia lead to extracellular potassium shift. Hypokalemia lead to extracellular potassium shift balanced with concomitant intracellular hydrogen shift. We discussed this before. This is bicarb generation by the distal tubule due to increase the hydrogen secretion due to increased distal delivery and subsequent absorption of sodium in the primary aldosteronism. Use thiazide or loop diuretics, Gentleman-Barter syndrome, infusion sodium penicillin. Also, all this will lead to more sodium reabsorption, more potassium and hydrogen secretion, hydrogen loss, and this bicarb gain. Exogenous and endogenous mechanism resulting in generation of metabolic alkalosis. Example here for exogenous sodium and potassium alkali salt like baking soda, sodium bicarb tablet, and potassium bicarb, potassium citrate, polycitrakase, citrate 2, and sodium citrate is added to anticoagulation for whole blood or fresh frozen plasma, and can be an important source of alkali in patients needing massive amount of blood transfusion. This to reduce large dose of plasma exchange. Bicarb is generated upon complete oxidation of citrate, acetate, lactate, another source, all of which are organic anions. Loss of HCl due to vomiting, NG suction, resulting in bicarb generation also. It is useful to recall that loss of hydrogen is equivalent to gain of alkali and vice versa. Infusion of large amount of sodium penicillin or other sodium salt or of non-absorbable anion such as sulfate or phosphate will generate bicarb by oxidation. Sodium reabsorption via the distal tubule is enhanced by volume depletion or mineralocorticoid like aldosterone. The sodium is reabsorbed while bicarb is generated and hydrogen is secreted at a titratable acid or ammonia. To maintain metabolic alkalosis under normal circumstances, the kidney can excrete bicarb and restore acid-base balance in under normal situation of our normal body. Normal kidney have a numerous ability to secrete a large amount of bicarb, around 400 milligram per kg per day. This can be secreted by our normal kidney. 400 milligram per kg per day. Bicarb can be secreted normally by our normal kidney. Failure of your kidney to secrete this amount of bicarb due to presence mechanism which lead to maintenance of metabolic alkalosis, decreased bicarb filtration due to decline of the GFR, or increased bicarb reabsorption secondary to volume depletion of proximal complement tubule, increased hydrogen secretion and ammonium secretion due to hypokalemia, and increased aldosterone also. All this mechanism will lead to failure of excretion of your bicarb and lead to maintenance of metabolic alkalosis, either decreased filtration from decline in GFR, increased carb reabsorption, proximal tubule, secondary to volume depletion, or increase the hydrogen secretion and ammonium secretion due to hypokalemia and increase aldosterone. Some clinical events activate more than one mechanism to maintenance of metabolic alkalosis. In summary, for example, volume depletion will keep volume and chloride depletion, this volume contraction alkalosis or effective arterial blood volume depletion, all this will lead to maintenance of metabolic alkalosis. Increased bicarb filtration due to decrease in GFR, this is another cause. Increased proximal tubular reabsorption of bicarb, enhance hydrogen secretion and ammonium secretion due to increased aldosterone, subsequent hypokalemia at the end. All this will aggravate maintenance of your metabolic alkalosis. In general, when you will see any patient with metabolic alkalosis, you will divide either chloride or saline responsive alkalosis, normal saline, not half or ringer lactate, or chloride saline resistance. We'll come to that. Metabolic alkalosis as regarding general Cushing, Cons, licorice, and penicillin derivatives, IV bicarb or bicarb oral diuretic use, thiazide loop diuretic. Causes of metabolic alkalosis, metabolic divided into, as I told you, metabolic alkalosis ECF, effective extracellular fluid volume contraction or volume expansion. You will check your chloride if less than 20, this with volume contraction, if more than 20 with volume expansion, contraction alkalosis. Whenever there is an extracellular fluid volume depletion or contraction associated with fixed amount of bicarb. This is another slide from social media. Loss of gastric juice here, and potassium hosting hypokalemia or diuretic, and overuse of antacid, PI. All this will end by metabolic alkalosis, and this is the causes already we mentioned for metabolic alkalosis by the mechanism. This is another table from just highlighted the most common cause of metabolic alkalosis. You will see in a patient with volume contraction, either vomiting, NG suction, the most common cause, high volume, ileostomy, patient with ileostomy, colostomy, whatever, with high outflow, and the patient post-hyperactive state, patient COPD in ICU, thiazide or loop diuretic. The most common cause, other cause like congenital chloriduria and plus adenoma, cystic fibrosis, Bartter syndrome, Gentleman syndrome. Patient with volume expansion, the most common cause, patient with, we are so many patients in CCU, cardiology, acute congestive heart failure patient on diuretic, you will see the carb shooting up and the CO2 rising with that. The another cause, primary aldosteronism, renal artery stenosis, renal secreting tumor, glucocorticoid remediable aldosteronism, Cushing syndrome, or disease exogenous mineralocorticoids, congenital adrenal hyperplasia due to 11 beta hydroxylase deficiency, licorice, reduced activity of 11 beta hydroxysteroid dehydrogenase, and Liddle syndrome. All this lead to volume expansion, metabolic alkalosis. The important cause of metabolic alkalosis in which volume status is variable include hypokalemia, can lead to metabolic alkalosis. Just correct the hypokalemia, metabolic alkalosis will be corrected. Hypomagnesemia, milk alkali, calcium alkali syndrome, where many patients have reduced GFR, limiting bicarb excretion, alkali load, especially with reduced GFR, non-absorbable aniline like penicillin and the carpenicillin, and reviving post-fasting or starvation. This will lead to metabolic alkalosis, also from hypokalemia, hypomagnesemia, whatever. Why does vomiting cause metabolic alkalosis? The most common question for you, nephrology. While vomiting cause metabolic alkalosis, typical cause of metabolic alkalosis associated with volume contraction and vomiting and energy suction. The most common cause of metabolic alkalosis is volume contraction, either vomiting or energy suction. Gastric hydrogen potassium ATP secretion, secreted HCl hydrogen potassium ATPs in the wall of the gastric or in the stomach. It will lead to secrete HCl into the stomach lumen. When ال HCl reach small bowel, لما ال HCl اللي جاي من الستومك reach small bowel, it will be neutralized, بيتعادل، بيعملوا له معادلة by equal amount of bicarb secreted from small bowel lumen. Removal of this gastric HCl by vomiting or NGT suction result in metabolic alkalosis because bicarb is added to in extracellular fluid rather than secreted into small bowel. This bicarb will be reabsorbed again or not secreted because no HCl to be neutralized. Bicarb is subsequently secreted by the kidney as the sodium bicarb, resulting in volume depletion more. If bicarb will be high, some bicarb will be secreted by the kidney, but this bicarb will take sodium and this will enhance naked channel down and more sodium reabsorption, more potassium and hydrogen secretion, more يعني will go to circle انك تلف في دايره كده. ان بيحصل برضه منها ميتابوليك الكالوزيس نتيجه الهايبوكاليميا ولوس الهيدروجين والبوتاسيوم فروم هاي صوديوم بايكارب بلس to inactive channel down. And metabolic alkalosis maintained in vomiting and energy suction due to volume depletion, secondary to aldosteronism, loss of potassium due to secondary aldosteronism, and increased distal delivery of sodium bicarb. As I mentioned before, this is a job of inactive channel as we discussed in previous presentation. Moreover, hypokalemia also shifted potassium extracellular and subsequently will take a hydrogen positive cation intracellular. Intracellular acidosis stimulate further bicarb generation. This intracellular acidosis from hypokalemia. انت مع الهايبوكاليميا البوتاسيوم will be shifted from intracellular to extracellular. لو عندك البوتاسيوم قليل في الدم بيؤدي لشفت البوتاسيوم من intracellular to extracellular with replacement with hydrogen. The intracellular acidosis will stimulate intracellular inside the cell. Now acidosis will increase, will stimulate more bicarb generation. Urine chloride in this case will be than 20 and urine sodium can be elevated due to excretion of sodium with bicarb by the kidney. To secrete the bicarb will not secrete alone, will take sodium with it. Second question common for us as a nephrology, why or when does diarrhea can cause metabolic alkalosis? We know already diarrhea causes mostly non-NGAB metabolic acidosis. In villus adenoma result in metabolic alkalosis due to loss potassium in stool and volume depletion. Likewise, congenital chloridorrhea also result in metabolic alkalosis. The latter is the rare autosomal disorders due to mutation of gene SLC26A3 resulting in loss function of alien bicarb chloride exchangers is pendrin and subsequent bicarb retention. Discussed this before in our diagram. Congenital chloride diarrhea, inherited autosomal recessive disease. Chloride absorption in the ileum and colon is decreased to mutation in this chloride bicarb exchanger, resulting in stool loss of chloride, extreme large vehicle loss of sodium, potassium, and water, resulting in hypokalemia, volume depletion, and metabolic alkalosis. Same scenario. Secondary hyperaldosteronism increase the body volume by sodium and water reabsorption while promoting the maintenance of alkalosis by secreting potassium and hydrogen. Please don't forget that if you will go to inactive channel in the distal tubule and the collecting tubules, it will activated by aldosterone. Don't forget that. We discussed this before in hypokalemia or hyperkalemia. More sodium reabsorption, more potassium and hydrogen secretion, loss hydrogen or loss acid in alkali. Don't forget this is the mechanism. Urinary chloride and the potassium level are low because of their loss in stool. The other mechanism of metabolic alkalosis. If the chloride decreased, the drainage channel will be activated. No more excretion of carb. Neonatal abdominal distension due to intestinal dilatation and maternal polyhydramnios are the clue for diagnosis of this disease, congenital chloride diarrhea. Villus adenomas is metabolic acidosis is common with this. However, some patients develop metabolic alkalosis. Fecal loss of sodium chloride and the bicarb and water seem to be generated and maintain metabolic alkalosis. Laxative, patient with laxative similar to villus adenoma. Laxative abuse can cause hyperchloremic metabolic acidosis. However, some cases report documented this metabolic alkalosis. Urine chloride and the potassium are low. Hydration with normal saline potassium supplementation and discontinuation of laxative improve metabolic alkalosis. Take care from medication history to diagnose your patient. Diuretic, and don't forget this laxative abuse to check the medication history. From history, you can diagnose what is the cause and you can treat easily within 24 hours. Diuretic and metabolic alkalosis, thiazide and group diuretic can result in metabolic alkalosis with volume contraction and hypokalemia due to enhanced distal delivery of water and sodium secondary and the secondary hyperaldosteronism. Same mechanism we discussed before. More sodium delivery to collecting tubule, more sodium reabsorption by neck under aldosterone effect, more potassium and hydrogen excretion. If you will excrete potassium, and potassium will be hypokalemia and will secrete hydrogen, you will lose acid. All this will end by gain of metabolic or maintenance in metabolic alkalosis. Urine chloride is variable. It is elevated more than 20 millimole, and when diuretic are working, when the diuretic are working and low less than when their effect wear off. Other cause like Bartter syndrome has multiple subtypes. It is a mutation in sodium potassium 2 chloride transporter channel and room K channel and Bartter protein. Manifestation of Bartter syndrome similar to use of loop diuretic, Gentleman syndrome, loss of function mutation of sodium chloride co-transporter and distal complete tubules. And it's equal to 24 loop diuretics Bartter and Gentleman equal 24 thiazide use. Diuretic use. Bartter syndrome is a rare genetic cause of severe hypertension because mutation due to gain of function mutation of inactive channel epithelial sodium channel resulting in hypokalemia from sodium reabsorption and potassium secretion with hydrogen and hyporeninemic hypoaldosteronism. Urine chloride is elevated more than 20 millimole in Bartter and Gentleman. Urine chloride elevated in Bartter and Gentleman because blocking the sodium chloride and the sodium potassium 2 chloride channel for these two genetic diseases. Most hypercapnic state patient with acute respiratory acidosis bicarb up by 1. Patient with acute respiratory acidosis bicarb will go up by 1 for each 10 millimeter mercury increase in CO2. 1 to 10. 1 to 10 now. 1 increase in bicarb for 10 increase in CO2 in acute respiratory acidosis, while in chronic 4 to 10. 4 increase in bicarb to 10 increase in CO2. Don't forget this. This suppose patient with acute respiratory acidosis, I will increase the bicarb to 10, 1 to 10 in acute respiratory acidosis, 1 to 10, 1 bicarb to 10 CO2, and in chronic patient 4 bicarb to 10 CO2 increase. This is another example here, and you can see and you can read. For example, patient with chronic respiratory acidosis and his CO2 is 70. Expected bicarb 36. This 24 hours is a normal bicarb will increase for this 3 around 3 now increase above 40 3 tons. That will give you the expected bicarb 36. And in the post-hypercapnic state, the respiratory acidosis has improved. As in COPD patients who are based on mechanical ventilation, but the elevation of bicarb resist resulting in metabolic alkalosis. Cystic fibrosis and metabolic alkalosis. Excessive respiration can cause metabolic alkalosis in patients with cystic fibrosis. Unexplained metabolic alkalosis. Take care from this clue or key point for this case. Unexplained metabolic alkalosis is volume depletion. Also, hyponatremia should raise the possibility of cystic fibrosis. But now we have unexplained metabolic alkalosis, volume depletion, hyponatremia. This will raise the possibility of cystic fibrosis. Presentation is common during the heat wave. Amino glycoside also can use in patients with cystic fibrosis can result in metabolic alkalosis due to Barrett-like syndrome. Amino glycoside activate also calcium sensing receptor, resulting in inhibition of sodium potassium 2 chloride. Balaminic glycoside can activate the calcium sensing receptor, and this will inhibit sodium potassium 2 chloride co-transporter action in the sick ascending limb, and it will increase the urinary sodium, potassium, calcium, magnesium. And activity H will be low despite hypocalcemia to activation of calcium sensing receptor. Take care from this point. Primary aldosteronism, a typical cause of metabolic alkalosis associated with volume expansion. This primary hyperaldosteronism with a thyroid volume expansion and primary aldosteronism commonly caused by unilateral either aldosterone secreting adenoma or hyperplasia or adrenal carcinoma. Primary aldosteronism manifestation, clinical picture, hypertension. Patient came by high hypertension or resistance or refractory hypertension, hypokalemia, metabolic alkalosis with volume expansion. Extracellular fluid volume expansion, distal sodium delivery, and enhanced reabsorption by aldosterone, resulting in volume expansion. This in turn increase potassium, and potassium will take hydrogen with him and will lead to aggravated hypokalemia. Loss of acid will end by gain of alkaline. Bicarb generation and retention are increased with hypokalemia as explained above in the previous slide, and the metabolic alkalosis maintained due to autonomous aldosterone secretion. Urine chloride in this case will be more than 20 due to effective extracellular fluid volume expansion. Diagnose metabolic alkalosis. To diagnose any patient with metabolic alkalosis, we'll go by step 1, history of any diuretic use, any exogenous intake of antacid, any calcium supplement, any laxative use, any licorice, and inquiring to vomiting. Any patient is history of vomiting, bulimia, family or personal history of hypertension are extremely important. Compliant of alternating diarrhea and constipation is suggestive of patient with diarrhea and constipation is suggestive of laxative abuse. Step number 2, you will examine your patient, blood pressure, hyper, orthostatic. You should check orthostatic hypotension. Volume status from neck vein, chest, and lower limb. Examination of teeth enamel, usually plaque due to gastric HCl from frequent vomiting or bulimia. You should examine the teeth of this, especially young female. You should examine the teeth for this plaque due to gastric HCl. Examination of the dorsum of the hand. Why? For this patient with bulimia, psychiatric patient. Examination of the dorsum of the hand for scarring and hypertrophy of salivary gland, also from frequent vomiting, habitual vomiting, psychiatric problem. Peripheral edema in young women unrelated to pregnancy and menstruation, suspect of diuretic use or idiopathic edema. This is another cause in examination. We'll go to lab serum electrolyte, BUN, calcium, magnesium, phosphate, and albumin, EBG to exclude chronic respiratory acidosis. Urine electrolyte as possible and pH, and the urine chloride is the most important electrolyte to differentiate between chloride responsive and chloride resistant metabolic alkalosis. Serum anion gap increase in metabolic alkalosis, increase in albumin. 2. Serum anion increase, if increase in metabolic alkalosis, increase secondary to increase in albumin with negative charge on it. Increase in glycolysis due to stimulation rate limiting enzyme, phosphofructokinase, and lactic acid production. Also, anion gap up to 8 milliequivalent per liter has been observed. Its clinical importance has never been appreciated in metabolic alkalosis. In this diagram, just take a picture and keep in your phone. For evaluation metabolic alkalosis, you should go to urine chloride of diagnose now my patient by LBG metabolic alkalosis. You go to volume assessment and urine chloride. Urine chloride if less than 20 or less than 10. Just keep in your mind less than 20. Just rule out vomiting. Rule out diuretic use, villus adenoma, cystic fibrosis, and exogenous alkali ingestion by checking your medication, post hypercapnia, patient with COD or respiratory in ICU. If the urine chloride more than 20 and the urine potassium less than 20, this laxative have used severe potassium depletion. If the urine potassium more than 20, If the blood pressure is low, blood pressure is low, Bartter-Gentleman syndrome, urine calcium will be low in Gentleman syndrome, urine calcium will be low, but will be low, and the other side will be high, Bartter syndrome. Differential diagnosis, urine calcium will be low in Gentleman. Hypertension, plasma renin, if low, just primary aldosteronism, licorice and little syndrome. If high, renovascular, this high renin, high aldosterone, this or high renin, this we'll see in renovascular hypertension, malignant hypertension, and Cushing syndrome. This is a simple diagram from our textbook, and I will show the reference later. Metabolic alkalosis is an elevation of blood pH, again more than 7.45. EPGs are required to diagnose acid-base disorders because high serum bicarb results from metabolic alkalosis or metabolic compensation of respiratory acidosis. History can identify potential causes of metabolic alkalosis, such as common vomiting, diuretic use, licorice intake, cystic fibrosis, exogenous source of bicarb, or primary aldosteronism. Medical exam help to evaluate extracellular fluid volume status, hypovolemic or hypervolemic. Most clinicians make the diagnosis of metabolic alkalosis inappropriate in clinical settings such as general كده by your experience and after your hair fall like me, but just by clinical experience, just ask for vomiting, NG suction, and you should rule out primary aldosteronism if you see hypertension, hypokalemia, metabolic alkalosis, just by spot diagnosis. Any patient with new consult for you based on history and physical exam and the basic chemistry profile without doing KPG. Basic chemistry, as we mentioned before, measurement or electrolytes, sodium, potassium chloride, magnesium is critical, and beside the ABG and urea and the creatinine help in evaluation of renal function. Urine electrolytes, the most important one, urine chloride is low in volume contraction. This is more than 20, this volume expansion, less than 20 is volume contraction. Patients suspected of having primary aldosteronism require further testing like plasma renin, aldosterone, whatever. And in Gentleman-Bartter syndrome needs some genetic studies. And the patient, another patient with primary hyperaldosteronism or congenital adrenal hyperplasia need special referral. Okay. Patients suspected having primary aldosteronism require further testing. As I mentioned, and Bend-Rate syndrome. Just an exam question: what is the Bend-Rate syndrome? Is it a autosomal recessive disease characterized by deafness and thyroid goiter? If in one case presentation came for you for metabolic alkalosis with Bender syndrome, query Bender syndrome, patient came by deafness. In your exam question, you will see or deafness or thyroid goiter. Its mutation is LC26A4 encodes this gene encodes for bendrin. Bendrin, you remember bendrin? Bendrin were responsible to reabsorb bicarb and secrete hydrogen in the beta intercalated cell in the collecting duct and cortical collecting duct, which are expressed also in thyroid gland and the inner ears. This bendrin channel expressed also in thyroid gland and the inner ears and the apical membrane of the intercalated cells in the cortical collecting duct of the kidney. Bend-Rate syndrome patients do not have renal abnormalities under basal condition. They are at risk for developing life-threatening metabolic alkalosis in case of volume depletion or treatment with thiazide diuretic. If thiazide diuretic is added, this is life-threatening alkalosis. If we give this patient more diuretic, more volume depletion, if you will add more acetazolamide, this will be life-threatening and profound salt wasting and lead to acetazolamide down-regulates bendrin more and is worsening your case. If I have one patient with deafness, thyroid goiter, and given thiazide diuretic, and he's more volume depletion and more worsening alkalosis, and given acetazolamide and more worsening, what's your diagnosis? Bend-Rate syndrome. Okay. Just in what is the clinical presentation like any acid-base disorder, especially in confusion, decreased level of consciousness, dizzy, irritable, nausea, vomiting, diarrhea, tremors, muscle cramp, tinglings, and hypokalemia we'll see also. And patient restless and agitated, dysphagia ممكن تلاقي tachycardia ممكن تلاقي hypoventilation. And these are causes of metabolic alkalosis. The most common cause severe vomiting, GI suction, diuretic, excess bicarb infusion. Severe metabolic alkalosis affects several organ systems, include central nervous system, neuromuscular, cardiovascular, pulmonary system, in addition to several metabolic abnormalities. This is central nervous system from reduction in the blood flow, confusion, obtundation, reduced seizures ratio, reduce cardiac output, reduce coronary blood flow, arterial vasoconstriction, increase heart rate, disposition for refractory ventricular tachycardia, supraventricular arrhythmia, SCVT, hypoventilation from pulmonary side, hypercapnia, hypoxia, metabolic hypokalemia, decreased ionized calcium, hypophosphatemia, and hypomagnesemia. From reduced central nervous system, first I'll come to clinical picture of any acid-base disorder by central nervous system for our metabolic alkalosis now. Reducing the blood flow to central nervous system from volume depletion, confusion, obtundation, reduced seizure, and the patient will develop seizure. We'll go to neuromuscular, increase the muscle or nerve excitability, and the cardiovascular, decrease output, decrease coronary blood flow, arterial vasoconstriction, increase heart rate, and dysrhythmia, pulmonary hypoventilation, hypercapnia, hypoxia, metabolic, the most common, hypokalemia, decrease ionized calcium, hypophosphatemia, hypomagnesemia, all these symptoms of metabolic alkalosis, tingling, numbness, muscle twitching, cramp, arrhythmia, irritability, dizziness, confusion. This is a clinical picture or signs of metabolic alkalosis. Most patients with mild to moderate metabolic alkalosis, most of them asymptomatic, serum bicarb up to 40 is tolerated. The manifestation usually due to concomitant hypokalemia, hypophosphatemia, hypoventilation, volume depletion, hypocalcemia. Manifestation of hypokalemia associated with hypokalemia, manifestation will appear as secondary to hypokalemia, hypophosphatemia, hypocalcemia, hypoventilation, volume depletion. Metabolic alkalosis decrease ionized calcium level. Severe metabolic alkalosis more than 45 can lead to tetany, seizure, cardiac dysrhythmia, and delirium. Alkalemia also inhibit respiratory drive and shift oxygen hemoglobin dissociation curve to the left. Treatment of metabolic alkalosis, you should address the specific cause and correct it. You should give your time, take your time in the history and check medication and share skill family and relative. You will catch the cause, and if you can catch the cause, you manage your patient to finish. Volume assessment, as I mentioned before, you should check this patient volume depleted or volume contraction, chloride responsive, chloride resistance. Administer potassium chloride if you will see hypokalemia. Don't think, just start your hypokalemia management. Don't use ringer lactate. The best fluid you will use is normal saline. Volume depletion, you will use normal saline. Just normal saline here is the best solution to replace the volume depletion and the chloride together. Don't use half normal saline. Don't use ringer lactate. Lactate will be transferred to bicarb and worsen alkalosis. Other centers, if you have experience, you can use this intravenous hydrochloride or ammonium. I don't have experience by this hydrochloride and ammonium and arginine HCl, but I don't think anyone use that. Acetazolamide. We are commonly used in patients with CCU, pulmonary edema, or congestive heart failure exacerbation. We are giving just 250 BID or TID for 1 or 2 days, maybe maximum 2 days or 3 days. And you should observe that because is bicarbonate and uric also. This will lead to more potassium loss and more hypokalemia, and maybe will end up also by metabolic acidosis. You should don't give and leave for cardiology. You should for your patient and just give maximum 2 or 3 days. Also, in renal failure, patient fail to respond to chloride repletion, renal replacement supervisor hemodialysis. I think hemodialysis is respectable here. Patient with protracted vomiting or prolonged NG suction, H2 blocker such as ranitidine, no one uses them. Ranitidine, in hydrogen potassium ATPase inhibitor such as omeprazole, can plant acid production in the stomach and reduce HCl loss. Omeprazole effective in treatment of alkalosis in patients with diatheroscystoplasty. Octreotide used to control hypergasturinemia in patients with Zollinger-Ellison syndrome. This octreotide can be a treatment also in this scenario. In patients with metabolic alkalosis associated with volume contraction, chloride-sensitive metabolic alkalosis is critical to give isotonic saline. Don't forget this potassium and normal saline. Potassium, normal saline for management inhibition metabolic alkalosis until proof otherwise. You can give iso if the patient volume depleted. Isotonic saline, 0.9% sodium chloride, and replete potassium with potassium chloride orally or intravenous as according to severity of hypokalemia and the availability in your center. This strategy will lead to sodium bicarb diuresis and restoration acid-base balance. Magnesium should be depleted in patients with hypomagnesemia because hypomagnesemia can result in refractory or recalcitrant hypokalemia. Diuretic should be discontinued if available, otherwise diuretic dose should be reduced, especially in patients with congenital heart failure, either to decrease the dose or stop or change it to acetazolamide. In some patients, such as those with heart failure or liver cirrhosis, discontinuation of diuretic is not an option. In those cases, addition of potassium-sparing diuretic like spironolactone and the common used already may be helpful in, because this will do balance for hypokalemia, hypomagnesemia, and the same time treatment for volume overload for this patient. Acetazolamide, this is a bicarbonate uric. However, it is very highly uretic. This need aggressive potassium monitoring and replacement. Okay, it should only be utilized by experienced clinician. Acetazolamide, it can be given oral or IV, or IV, but we already gave him oral 250, 500, either 2 or 3 times daily for 2 days, maximum 3 days. That the Apollo studies is another study with double-blind randomized trials on 15 intensive care units in France, and they involved 382 patients with COPD, mechanical ventilation, with pure mixed metabolic alkalosis. Patients in active harm were given large dose of acetazolamide, 500 to 1,000 twice daily. Acetazolamide did not change the primary outcome, which was a reduction in the duration of invasive mechanical ventilation via endotracheal intubation or tracheostomy. There was statistically significant small reduction by 0.8 millimole per liter. Already we have experience with that. He's working maybe in most of our fewer patients. Patient with metabolic alkalosis and volume expansion. Chloride resistant metabolic alkalosis should have their potassium replaced as well. Underlying etiologies such as adrenal adenoma should be the main focus treatment. You should search for secondary causes. Bilateral adrenal hyperplasia treated by aldosterone blocker such as spironolactone or eplerenone. We are experienced with spironolactone. Low potassium diet is helpful. Low sodium diet is helpful in patients with high aldosteronism because it reduces distal sodium delivery. The known mechanism, peritoneal dialysis or hemodialysis with a low bicarb in a dialysate. You can use in dialysis patient low dialysate bicarb. 30, 32, 35 are helpful in correcting metabolic alkalosis in patients with advanced CKD in dialysis or renal disease. Also, CRRT is helpful in management of severe metabolic alkalosis, the ability to modify electrolyte in replacement solution and the dialysate. Prolonged exposure to an appropriate high dialysate bicarb should increase mortality due to post-dialysis metabolic alkalosis. Currently, bicarb in dialysate is kept around 35 millimole per liter. Infusion of this hydrochloride, as I mentioned before, or sodium chloride and ammonium chloride, we don't use and need experience center. The etiology of metabolic alkalosis should be addressed. Patient with vomiting should be treated symptomatically, and the cause of vomiting should be investigated. The use of H2 blocker may be helpful in patients with ongoing gastric fluid loss. Exogenous source of alkali should be identified if a patient taking any bicarb from outside, oral or other medication like laxative. Patient should be instructed to avoid licorice containing tobacco product. Now, in tobacco also containing the licorice. Porter syndrome is treated with potassium repletion, potassium sparing diuretic, spironolactone also can help, and non-steroidal also. Due to prostaglandin blocking also can help. Gentleman syndrome, treated with similar manner, magnesium repletion, balanced ETAL evaluation treatment with indomethacin and diuretic amiloride or eplerenone in 30 patients with Gentleman syndrome. Indomethacin was the most effective with 0.38 millimole per liter increase in plasma potassium, followed by amiloride 0.19 millimole per liter increase, and then eplerenone 0.15 millimole per liter. It's noteworthy is 40% of the patients receiving indomethacin discontinued treatment due to GI side effect. Homocystic metabolic alkalosis is the most common acid-base disorders in hospitalized patients, importantly associated with increased mortality. Metabolic alkalosis generated by either gain of alkali or loss of acid. The process is maintained by failure of your kidney to excrete excess alkali. Metabolic alkalosis either associated with volume depletion or volume expansion. Volume depletion metabolic alkalosis is chloride sensitive and is treated just only by normal saline and the potassium replacement, while the volume expansion metabolic alkalosis is chloride insensitive or resistance and is treated with potassium repletion and addressing the underlying cause. The molecular mechanism of several genetic disorders associated with metabolic alkalosis have been elucidated, such as Bartter-Gitelman-Liddle and Bender syndrome. Go to some cases. 74 years man, admitted to hospital with severe vomiting, abdominal pain, small bowel obstruction. EG suction was started the following day. Lab test shows sodium 134, potassium is low, 2.4, chloride 92, bicarb is high 36, pH 7.5 is high, CO2 48, urine sodium 141 is high, urine chloride is low 4. What's your management for this patient? The pH is high 7.5, this is alkalemia, bicarb is elevated, and urine chloride is low, chloride sensitive metabolic alkalosis. He has adequate respiratory compensation. If you will calculate the partial arterial CO2 40 plus 0.6 multiply by 36 minus 24, 74. This is nearest. This is our CO2 already in our case. The metabolic alkalosis due to severe vomiting energy suction. It's critical to replace potassium and initiate volume repletion with 0.9% saline, isotonic saline. It's number 255, old woman admitted to hospital for management of acute chronic historic congestive heart failure, ejection fraction 15%, starting furosemide 18 milligram every 8 hours, metronidazole 10 milligram daily. Her symptoms start to improve, but remain significantly hypervolemic. What you will do? Lab test for him, sodium 144, little bit pain, potassium is low, chloride 100, bicarb is high, magnesium is low, and pH 7.5, CO2 50, urine sodium is high, chloride is high. How would you manage this patient? The patient had compensated metabolic alkalosis due to a use of diuretic, exhibited BSO2 40 plus 0.6 multiplied by 38 minus 24, 48.4. This actually near this 50. This is equal now. This is appropriate compensation. Those of furosemide and metronidazole was held diuretic were not stopped. This patient remain hypervolemic. Both came magnesium were aggressively replaced in this patient, magnesium and potassium. The patient was started on a spironolactone. We add for him spironolactone. So for potassium sparing, magnesium sparing diuretic. Addition of acetazolamide was contemplated here. If metabolic alkalosis did not improve with the previous spironolactone, I will add here acetazolamide. Acetazolamide used, it should be only short-term basis, just 2 days or 3 days, 500 or 250 BID for 2 or 3 days. Acetazolamide is caliuretic, especially patient is already on low diuretic, will lead to aggressive or more worsening hypokalemia, and this will aggravate again this your metabolic alkalosis. 63 years man, medical ICU, severe sepsis, UTI origin urosepsis, And second day he developed pulmonary edema, started in bumetanide, diuretic every 8 hours, metolazone, and his sodium 145, potassium is low, chloride is 106, bicarb is 22, little bit low, and pH 7.32 is low, and CO2 44. What is the acid-base disorders? pH 7.32 with acidemia, bicarb is low, this is metabolic acidosis now. BCO2 expected here 38. We calculated already as a previous equation 38, and his BCO2 already 44, consistent with respiratory acidosis also in this patient. Due to pulmonary edema, we have metabolic acidosis now from sepsis and complicated by respiratory acidosis from pulmonary edema overload. Anion gap is 17, delta anion gap is 7, and delta bicarb is only 2. Indicates the present concomitant also metabolic alkalosis if we calculate delta, which has led to a rise in bicarb. The patient had a triple acid-base disorder now, anion gap metabolic acidosis due to sepsis, metabolic alkalosis due to diuretic, and respiratory acidosis from pulmonary edema. This is an interesting case already. A fourth case, 45 man with severe hypokalemia, metabolic alkalosis, potassium 2.3, bicarb 32, blood pressure little as high. Details history revealed consumption of large amount of licorice, which has used as a snake. Licorice causing this presentation. Active metabolite of licorice is glyceritic acid. This glyceritic acid is an inhibitor for enzyme 11 beta hydroxysteroid dehydrogenase type 2. But now licorice metabolites is glyceritic acid. Licorice metabolized to glyceritic acid. Glyceritic acid is an inhibitor of the enzyme 11 beta hydroxysteroid dehydrogenase type 2, which convert the cortisol active form to cortisone. Now we have this cortisone is high now, he work like aldosterone. Subsequently, cortisol result in mineralocorticoid effect, including hypokalemia and sodium retention, metabolic alkalosis, and hypertension. This will activate the scenario of inactive channel and aldosterone. Some tobacco product contain licorice. Take care from that. Last case, 43 years women received large doses of diuretic, management acute and chronic congestive heart failure. ABG showed pH 7.5 and PCO2 50, bicarb 40, and potassium 3.4 low, bicarb 39. As we mentioned, what is acid-base disorders here? Under the patient had a simple acid-base disorders compensated metabolic alkalosis due to diuretics, PCO2 40 plus 6.6, 14 multiplied by 40 minus 24 is 49.6, and the actual is 50. And this patient just the simple acid-base disorders compensated metabolic alkalosis. Don't forget this is the renal mechanism of increased bicarb reabsorption, and this, as we mentioned, as we discussed before, if you would like to review all the mechanism here. Conclusion, metabolic alkalosis means increased pH more than 7.5, also increased bicarb, but this compensated by increased PCO2. Pathogenesis of metabolic alkalosis either by gain, include two mechanisms, either generation or maintenance. Generation either by gain of alkali or loss of acid, maintenance metabolic alkalosis by increased tubular bicarb reabsorption, failure of our kidney to excrete this excess alkali. Metabolic alkalosis is the most common acid-base disorder in any hospitalized patient, particularly in surgical critical unit. And this diagram to show you the difference between metabolic alkalosis and metabolic acidosis. And this metabolic alkalosis, another diagram, metabolic alkalosis according to volume status, hypervolemic mineralocorticoid excess, hypovolemic urine chloride less than 20 or 10, vomiting diuretic more than that, urine pH, you will go to vomiting bicarb diuretic or laxative of urine pH less than 6. In this diagram already we discussed in the first slide, volume depleted, volume expanded, low urine chloride, differential diagnosis, high urine chloride, diuretic barter gentleman, and volume expansion, high PRA, low PRA, renal artery stenosis, renal secondary tumor, low PRA, plasma renal activity, like adenoma and aberrant mineralocorticoid, glucocorticoid, remediable aldosteronism, Cushing-Liddle syndrome. And this is our reference manual textbook of fluid electrolytes for both اللورا ريدي and دكتور محمد تيناوي. واتمنى يا رب تكونوا استفدتوا اليوم. ونسألكم الدعاء بالتوفيق والسداد والبركة في الصحة ونسألكم الصحة ونسألكم البركة في المال والأهل والأولاد والصحة والعافية، ولا تنسونا من صالح دعائكم، ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. نلقاكم إن شاء الله قريبا بفيديو مهم جدا لحالات انترستنج إن شاء الله تتقدم خلال اليومين اللي جايين، ونسألكم دعاء بالتوفيق والسداد والبركة في الوقت، ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم، ونترككم في رعاية الله وحفظه. السلام عليكم ورحمة الله وبركاته.